Good afternoon, everyone, and welcome to our fifth presentation in our Reducing Preventable Hospital Readmission webinar series, where we're focusing on targeted strategies for improving care transitions in our Virginia hospitals. I'm Joyce Dayvault, and I'm the Director of Performance Improvement here at the VHHA Center for Healthcare Excellence, and I'm your moderator for this series and this presentation today. So before we get started with our presenters, I'd like to cover a few housekeeping items with you, please. As you will see, as we have done before, the webinar is being recorded. The presentation was sent to you in an email previously and is also in the handout section of the webinar platform. We ask that you use only the telephone option, and just so that you know, all participants are muted from our end. However, I ask that you please do not put yourselves on hold because we will hear your music from your hospital or your advertisements that you have on your phones. So please don't put us on hold. And as we engage after the presentation, we ask that you would type your questions in the question box, as you'll see on the webinar platform. And also, before we are completely finished, there will be a feedback survey at the end of the launch of completion of the webinar. And we very much appreciate your input to let us know what you thought of the presentation and how we can be of additional assistance going forward. Your ideas and input are very important to us. As you'll see, the purpose and objectives of our series has been to share and identify and share successful strategies in use in our Virginia hospitals and health systems that are promoting care transitions and reducing hospital readmissions. We also want to increase the transparency and facilitate networking among you all, and that's the purpose of this program. This is just a list of the presentations that have already been done, as you'll see the check mark beside them, and the future ones that we're having, the next one being September the 26th. So at this particular point in time, I would like to introduce our presenters for today. Virginia Commonwealth University Medical Center is actually going to be, our presenters are going to be addressing MultiVisit patients entitled Bending the Utilization Curve. I would like to introduce our presenters, Ryan Razik, who is the Associate Vice President of Coordinated Care and Post-Acute Services, and Deborah Ware, who is a Project Manager in Performance Improvement within the VCU healthcare system. Welcome, Ryan and Deborah, and the floor is now yours for your presentation.
Thank you.
Thank you, Joyce. I appreciate the introduction, and thank you to everybody for carving out a few minutes of your busy days to hear a little bit about our journey here at VCU Health as it relates to multi-visit patients as well as readmissions and how they sort of tie together. My throat's a bit scratchy today, so bear with me as we'll try to get through this, and hopefully you'll have a few points that you can take away with you. So I know we're short on time. Next slide, please. So we'll jump right in. So I want to give a shout out before we get started here to Dr. Amy Botwell, who many of you probably worked with. And our first kind of delve into this MVP work formally was, I guess, about 18 months ago. And maybe a year ago, we started participating with the American Hospital Association Collaborative on reducing multi-visit patients, and that was led by Dr. Amy Botwell and team. And so the next 4 slides are some slides that were provided by her group that helped to kind of launch that work, but they do a great job of sort of framing it. So wanted to spend just a few minutes getting started. You know, who are the population that we're talking about? So we've adopted the term MVPs, or multi-visit patients. It's been adopted by the QIO here as well as the AHA. You guys have probably all use different terminology, from frequent flyers to familiar faces, VIPs. But this is the term that we've adopted to represent patients who have 4 or more inpatient admissions in a rolling 12-month time frame. It's also probably important to hit on here, 4 or more was adopted here locally with the QIO and the AHA, but you could adjust that up or down based on your population. So, you know, I would recommend running 4, seeing where you are at from a volume perspective, but you know, you may need to decrease that or increase that slightly to get to a manageable population that you really want to look at. Next slide. So this is one of my favorite slides. I think it does a good job of showing the myriad of issues that exist with our patients that are coming to the hospital this frequently. But basically, we like to break them up at Amy and team's recommendations into medical, behavioral, and social buckets. And as most of you guys know, you know, what we consider to be sort of the MVP syndrome, often there's co-occurrence of those needs. Rarely is it one. It's typically not just a medical issue bringing the patient back sometimes, but more often than not, there's at least two of those buckets, if not all three. And part of what our goal is in this work is to try to understand which buckets is that patient experiencing issues or concerns in, and how are they impacting the underlying medical plan and keeping that patient from being successful outside of the inpatient setting. Next slide. So to, again, kind of frame up who we're talking about, if you're engaged with your emergency room in this discussion, you'll know there's two different buckets of MVPs. There is the emergency department MVPs, and those patients, you know, we've got patients that have come, you know, 250 times or more in a year, but they don't get admitted, right? So there's a distinct bucket of ED multi-visit patients or high utilizers, and then there's a bucket of inpatient MVPs. And they are overlapping. Certainly there's patients that experience both, and we've got a little data on what we saw, but they are distinct populations, and more often than not, they don't overlap, which we found a bit surprising as we got into our data. And you'll hear us talk about the drivers of utilization in just a minute, but it's important to think of these in distinct buckets, and we've got work going on in both, and certainly some of the interventions overlap and apply to both populations, but they're not necessarily one and the same. You may see a higher volume of social and behavioral needs on the patients that are coming to the ED but not getting admitted. You may see a higher clinical acuity on those getting admitted, and you may see something in between. So just want to point out, today our focus is going to be primarily on that right bubble there, the inpatient MVPs, but again, there's a lot of work going on in both spaces. Next slide, please. So this is another one of my favorite slides. So it's busy, and that's okay. We won't hit on everything, but the top bullet there I think is one of the most important. There can be in certain healthcare institutions across the country, there can be a stigma, right, associated with patients who are high utilizers of services. The patients that come in and the frontline team members already know their name or face when they see it pop up on the board. You know, you get a shoulder shrug or an eye roll. It's important, it's up to us and the folks on this phone and others in your organizations to try to change that paradigm and understand that that high utilization is a symptom of other issues. And if we don't understand that it's a symptom and start to understand the root cause, almost take a 5 whys type approach to understanding what's driving it, we're not going to be able to impact change. So we like to look at what's called the driver of utilization. And so that's that underlying root cause. When you strip everything else away, what's driving that patient back, what's keeping them from being successful with the care plans that we put in place. We have to understand that if they're coming into the organization and we're creating the same discharge plan and sending them back out in the same fashion as we did before, we're not going to break that cycle. So thinking, you know, the two takeaways from this slide for me are understanding that high utilization is a symptom and it needs to be treated as such, and then, you know, really getting to that driver of utilization. Next slide. So we're going to hit on a little bit of our data here. I know this probably not as important for other folks as it is internally here, but hopefully this will give you an idea of some things that might be important to look at as you go down this road or continue down the journey if you're already on it. For us, using that 4+ admission in 12 months, and our baseline year was our fiscal year 18, we saw 859 adult patients. We look at pediatrics as well. We keep a separate tracking tool with that, but the majority of our work to this point has been focused on adult, and so we wanted to kind of break those out. So 859 adults, about 4,000 admissions. There's some part that was very, very surprising to us. Perhaps it shouldn't have been, but one of the things that jumped off the page at us was we do about 40,000 admissions a year, so we had about 10% of our entire hospital volume was represented by fewer than 900 patients, which is a big number and something that you guys really should take the time to understand it if you haven't already done that. Back to the overlapping ED MVPs and inpatient MVPs, we saw about 44% of them had at least one additional ER visit. So once they met the criteria of 4 or more inpatient, less than half had another ED visit. And then if you say, well, how many of them were actually frequent utilizers in both buckets and met MVP criteria in both, it was actually only 15% of that total 859. And so that's where that overlapping of those two circles was, as I mentioned earlier, smaller than we expected. And that's why we've kind of broken our interventions and our work into two separate buckets there. A couple other points on this page. Just over 10% of our MVPs had 10 plus admissions. So a lot of them had the baseline 4, the baseline requisite to get in. And then it obviously ramped up from there. But we still had about 10% of those patients, or 80, 85 or so patients that had 10 or more in the year. We wanted to look at, opportunities for outreach. And so we wanted to look at our geographic distribution of patients. We did see that about 5 zip codes, relatively small number of zip codes, accounted for about a third of the patients. So some density in population, which has helped us to understand what kind of outreach programs we can put in place to support that population. And interestingly, and again, something that was fairly surprising to us around the table when we first got into this data, about 95% of those 859 do have a payer source. So our typical payer source in our broad general population, we have about 25% indigent as the safety net here in Richmond, but only 5% indigent in this bucket. And the hypothesis is that they've encountered the system so many times that folks have been able to get them enrolled into whatever programs may be applicable to them, as well as the fact that they're encountering the healthcare system so frequently, there may be more personal drivers to seek those resources out as well. Next slide, please. So last on our data here, we'll jump into interventions and spend the rest of our time on that. Excuse me. We use LACE as a sort of a broad risk tiering tool for risk of readmission and mortality. Not surprising, but all of the average score in this MVP population is high risk. So just helps us with identification. I know this particular educational series is focused on readmission, so obviously very important to us as well. By definition, a patient can be here 4 times and meet MVP criteria and not hit a readmission penalty, or get tagged as a readmission, 30-day readmission. So we wanted to understand, where do they overlap? And just over 59% of all MVP visits occurred within 30 days of a prior discharge. So about 60% would have counted as a readmission as well. And then you can see just a breakout down there of the days out of hospital. We had 14% back within a week, which is going to more than likely be a different driver of utilization than the 9.4% that were out greater than 90 days. And then you can see the distribution there was from 1 to 292. Next slide, please. So jumping into our interventions, the first thing we did is we wanted to create awareness and create tracking and create data and dashboards. So this is actually a screenshot of a dashboard that has been live for a little while, probably 6 months, maybe more now. We actually have an updated version of this in beta testing now that puts a number of other filters available to the end user, everything from diagnostic categories, payer, zip code, gender, demographic information, et cetera. So we're continuing to build this out and ramp it up, but even this was a great start to create the organizational awareness. So you can see here we break it out by unit. This particular dashboard, we have both historic data and real-time who's in-house data. So this here is who's in-house and gets updated on a daily basis. But you can see we can filter by unit. We've got admit date, basic demographic information, whether they came in as urgent, emergent, or elective, and then the admit source and the visit count there out at the end. And you can see a distribution across the bottom of where they reside in our current units. Again, this was great for creating awareness. So we had looked at all the data and we had numbers on paper, but just seeing the fact that we had, 70 patients in-house on most days out of, 700, 750 patients, the average daily census jumps off the paper at people. So really getting that organizational awareness, I think this was critical. Next slide. So we just bulleted these out as talking points, and we'll spend a minute or two here going through these and spend the rest of the time on this slide with what's currently available and hearing a little bit about what our journey has been like, and then what's under development. Again, sticking with the theme of organizational awareness, so we created the dashboard. It's a Tableau-based system or report, which is great. It's perfect for the end user, but we also know many of the end users that we would like to use that are not going to go and regularly pull down from a dashboard. So we also wanted to create push mechanisms. So we created a daily email that goes out, and Deb Ware, sitting right next to me, has been spearheading that for the last year. And so we take the information on a daily basis. We're pushing an organizational email to the key stakeholders that need to have this information to say, hey, here's who was admitted in the last 24 hours. Here's how many times they've been there, payer. Am I missing anything else?
Whether they use the ED as a source of admission, or also if they have advanced care planning documents on file.
So that's been, again, great. Just it's purely awareness. It also helps the discharge planners with prioritizing their work during the day. The next thing we did is, so we've adopted a tool from the industry, an assessment tool that is really geared at looking at those three buckets and helping us to understand that driver of utilization. And we modified it for our use a bit. And what happens is when the patients come in that meet the criteria, the discharge planning team is to use that modified tool over their sort of routine assessment. Many of the things are the same, but there's sort of a heightened focus. And one of the components on that comes out of that assessment is assessing the PCP status for the patient coming in. So we're looking at, do they have a primary care physician? When was the last time they were there? How frequently are they going? Are they engaged? And, is the PCP meeting the needs? We do see patients that come in with a variety of different subspecialists, but nobody necessarily quarterbacking all of that together. And our goal there is to assess, is it time in this patient's progression of care to look at one of our advanced health homes within our system? So we have, as I'm sure many of you do, we have it's sort of a patient-centered medical home on steroids a bit. So it's advanced health homes that have wraparound interprofessional services within. We look at whether it would be appropriate to talk to the patient about that. And our goal is to avoid breaking existing PCP relationships. We don't want to fragment care in any way, but is there an opportunity to get them to a home that might be able to better meet their needs, especially if one doesn't exist already? So that's a key component, especially as we look at access to behavioral health and substance abuse, which you'll see on the next slide is something we're building out. But is there a way to incorporate that into their primary care plan if that's a necessary component? We've also partnered with an agency outside of the organization, C3Rx, to do home-based medication. This is education and reconciliation. It's a post-hospital program. They follow the patient for a month. They go into the home. They can bubble pack. They do education. They can pre-fill pill boxes, et cetera. So we won't get into the entirety of the program, but it's been a very effective program for us, particularly for high-risk patients, either on polypharmacy or on a high-risk med list. As an example, the types of things you see when you get eyes in the home, we had a lady who had, probably 15 different medications. All the pill bottles were dumped out into a candy dish, the individual pills, and she just knew that she was supposed to take this one this time of day and that one that time of day. And so we were able to go through and help get her pre-filled pill boxes and then bubble pack and deliver. And those are kinds of things when you get eyes in the home, as many of you probably know. Continuing with the theme of providing support after they leave is we're partnering with the local agency on aging, Senior Connections, to provide health coaches for those particularly of high risk that are elderly. So We've actually brought the age down from what they typically followed to try to, maximize their reach, but we're looking at 60 plus there. And that's modeled after Dr. Eric Coleman's CTI model of care transition. So that's a program that's available to those individuals. We're obviously assessing for transportation needs. Do they have it? Do they need it? Is a barrier for getting to the appointments? Are they overutilizing ED or inpatient as a result of that? Are their diseases getting exacerbated because they're not going to their appointments, et cetera? And then helping them out any way that we can within the regulations. If they're going to a skilled nursing facility, we have a post-acute care team that follows them. So we have SNF geriatricians that attend in our local nursing homes. We're following them into the nursing homes. We're doing warm handovers. We've got a post-acute navigation team that's a nurse social work combo that's having weekly virtual utilization rounds with those skilled nursing facilities and following those patients' progression of care to make sure that once they're leaving the SNF, if they are leaving the SNF, that they've got home health set up, they've got follow-up appointments set up, et cetera. How are they progressing through that? So making sure that we keep structure with them as they go through. Most of you are probably familiar with the EDDI system here in Virginia, the ED Information Exchange, but we're trying to leverage that as an existing resource to embed care plans within that module so that we can see what's happening elsewhere as far as utilization and then embed care plans. One of our goals out of the gate here was that all of these individuals would have a care plan that crossed encounters, that it's readily identifiable in the EMR, and team members know where to look for it and know how to act on it and modify it. We started with the top 60, which was just a manageable number for us. There was no magic to how we got to 60. But we leveraged what we have as a complex disposition team, which is embedded within our care coordination department, nurse social worker team. They did proactive outreach to the top 60 utilizers on that list, worked their way from the highest to the 60th patient. And if we couldn't make contact with one, they just bumped down to the next one and started. But the goal of that call was to begin assessing over the phone before they came into the institution. Begin starting to understand the driver of utilization as much as you can telephonically, but starting to understand that we, let them know we want to help you with this. And we were able to we had some success stories just through that outreach. We had one lady who had kind of, in her words, hit rock bottom and was interested in seeking substance abuse help within our outpatient treatment center. And so we were able to connect her there before she had to come back into the ED. So simple success stories like that. And lastly on this slide is engaging our palliative care team to look at where is this patient in their disease progression? Do they have advanced directives in place? Are they at a point where we want to have advanced care planning discussions? Do they need palliative support? Do they need hospice, inpatient, or home, et cetera? And sort of proactively looking at that. Next slide. So this is our last slide. We just have a minute or two left, I think, to allow time for questions. But we have a lot of work still underway. So we're a year plus into this journey. We feel like we've made good strides. We are going to constantly build on this. This is going to be something that evolves over time. Just briefly, we want to create flags in the EMR so the reports are great. The dashboard is great. We want to have a patient-friendly flag that makes sense to team members who are working on that. I mentioned substance abuse and behavioral health. We know there's not vast amounts of resources in the community, though they may be growing, which is good, but incorporating that into this in a meaningful way is something we're focused on now. The modified assessment tool I mentioned right now it's in sort of we have it obviously in paper, but we also have it in like a templated note available to our team members. But we want to get that built into a full-blown assessment with drop-downs that we can extract data and information from as well that works in the flow of the team. We're building out pager alerts in the ED, and we are going to continue looking at outreach through things like telehealth and community paramedicine. So I know we're short on time, so I'll wrap up. I kind of breezed through those last few, but I think we want to allow time for questions. So I'll stop there. I will say, last comment is we are waiting now to close out our FY19 data to let us know how we've impacted year over year compared to FY18. However, based on what we've been watching week over week and month over month, I expect that we're going to see about a 5 to 8% reduction in the utilization in this population, which again doesn't sound like a huge amount, but when you're talking about a baseline of 4,000 visits, we're pleased with that as a first-year outcome. So hopefully we'll see that in our year-end data, and we can bring that back to another discussion. I'll pause there and just say thank you guys for participating.
Thank you so much, Ryan and Deborah. And right now we are watching the chat box for questions. If you all have any questions for Ryan or Deborah, then certainly please type them in the chat box now for us. I can't read it, so.
Maybe we answered them all, Joyce.
We've got 2 comments, I think, out there. I can't.
For the 60 patients.
Go ahead and read it. Teresa's going to read it for you, okay?
Okay.
For the 60 patients who were targeted for proactive care plan development, what was the general response by the patients?
Good question. Yeah, that's a great question. It was mostly positively received. I mean, we had to call probably 100 patients to get 60, maybe even more than that. You know, there was patients that we couldn't get track of or didn't want to speak with us. The ones that we did speak with were generally pleasantly surprised to hear from us. There was a few exceptions to that, but they were pleased that someone was reaching out, was taking an interest. You know, we went through the assessment. It's as good as a telephone assessment can be. But a lot of times we were able to get patients in. We would hear people that say that they felt like they were getting worse then, and so we were able to go ahead and get them, next day appointments and things like that. We weren't, I don't think we got to a point where we could put everybody in distinct behavioral, social, medical buckets just through that. But what our goal was to try to get them engaged, get them in to see their physician of record, and have them meet with one of the social workers when they got there and continue that conversation. And so we would begin the development of a care plan that we would put into, we're on Cerner, so we would put it in Cerner. But overall, I'd say it was positively received.
Yeah. Everybody was surprised that we would reach out just to see if they were having problems.
Yeah, very good. All right, well, we have several more questions that have come in, Ryan and Deb. So the next one is, what do your SNF relationships look like, and is your hospital linked to a SNF?
So we don't own any SNFs in this market. We do own a SNF in South Hill, Virginia through our Community Memorial Hospital, but that's about an hour to an hour and 15 outside this market, so it doesn't really impact this necessarily unless they happen to be down from that area, which was few. But we have a SNF preferred provider network, which is 13 facilities here in town. Went through a really extensive vetting process and have quality expectations and outcomes, communication expectations, monthly data review with a quarterly formal review of performance, joint operating committees, that kind of thing.
Okay. All right. The next question is, how do you manage populations that their symptoms are at their worst? An example like shortness of breath, and the readmission is inevitable. What resources do you suggest for these patients?
So, we have nurses making the calls, and we teach them if it's something like that, we're going to help connect them to 911 real time if it happens on the phone. If it's something that can be managed, we're going to get same day, next day appointments to any extent possible, whether that's with us or one of the federally qualified health centers. We work some with a local group that can do nurse practitioner visits in the home, so we can actually dispatch someone out to go do that. We have a transitional care program that can do some similar work, so it sort of depends on the issue. And just, one thing in that question that prompted a thought is, you got to be realistic in this population for sure. you're not going to impact everybody. And honestly, the folks at the top of the pyramid, the top 60, are probably the hardest to impact. I would even recommend maybe starting with the ones that had 4 and seeing if you can prevent them from becoming ones that have 10, for example. But there's going to be some challenging patients. You're not going to prevent them all. And frankly, not all readmissions are bad. If a patient needs to come back, we want them to come back and get that help.
Yeah, certainly. The next question is, it says, what is MVP? And that, of course, if you were late coming on the call, is multi-visit patient. And the question behind that is, how did you discern the stats from 900 patients accounted for the number of visits? A formula that I can share to run a report. We may have to do that in an email. I'm not sure.
Yeah.
Yeah,
I don't remember
we could connect by email. I mean, essentially, we took we looked at inpatient visits and then matched them back to MRNs. And it's more complicated than that, obviously, but we could connect if need be.
Good. And then the last question we have here is, are you finding that the new ED system to be useful as a tool in your program?
I think it's still in the infancy as far as the utility in this particular case. It's great for seeing utilization in other facilities. I think as more and more hospitals are getting information in there, it'll grow and become more and more useful. But we want to continue to push it forward. I think the utility will grow as time goes by.
Sure. And then we had one more question that was just added, and it said, are there any plans to work with EMS to transport patients to an alternative destination? Alternative meaning to a FQHC or a CBS?
Yeah, that's an excellent question, and short answer is yes. We are having discussions with some EMTs about that. So we're looking at sort of 2 forms of paramedicine, community paramedicine. One would be sort of how do we routinely go to the homes with EMTs and others to kind of watch patients on a monthly basis or whatever is appropriate, but then also to this question, when they call 911, is there a triage mechanism that we can triage them to another location? There's actually a CMS grant out right now looking at that very work, and so we are in discussions with that. It's not up and running yet, but we would love to be able to do that. Excellent question.
Thank you. Thank you. Thank you. Yes, some very robust questions, and we thank the audience for your participation and inquiry. I want to thank Ryan and Deborah both for their excellent and informative presentation for us today and for taking the time out of your busy schedule to be able to present the strategies that you've been working so diligently on and your team. So many, many thanks to both of you. Most appreciated, and our next presentation will be September the 26th. 12:30 to 1, and we'll actually have a discussion with Encompass Health on some of the work that they're doing there. So please, as you close out, do the feedback survey for us that will launch when you close out of the webinar. This concludes today's presentation.
Thank you.
Thanks.
Thank you.